Hello everyone, my name is Joshua Moore, and I'll be starting off our group presentation on Sexuality and Disability, a 1-hour continuing education course. Our learning objectives for the group are to recall basic introductory sexual issues related to hereditary disability, outline changes and challenges in sexuality related to aging, and identify the basic sexual challenges facing disabled veterans, which I'll be covering. This course is in compliance with the National Board of Certified Counselors Continuing Education Standards. Recommendations and feedback would be held for 5 years. Complaints, which can be provided to the number below, are submitted pending approval to the National Board of Certified Counselors within 60 days, and the complaint documentation is held for 5 years. Disability rights. Every participant has the right to the content of this presentation. Visually, auditory impairment or disability will be individually accommodated by request. Content restrictions. The course is not for distribution outside the classroom and not approved for copy or distribution in part or whole without the consent of Lindsay Bertram, Jeremy Pumphrey, or Joshua Moore. Digital content. All media is used with permission or the direct property of Lindsay Bertram, Joshua Moore, and Jeremy Pumphrey. So for my group presentation, I'm going to cover veterans, sexuality and disability with veterans. There's a large study done, a comprehensive study done on 12 years prior to 2013 on 50,000 injured soldiers. Of that group, 5% of them involved the genitourinary tract, which is like everything below the kidneys, the renal system, the bladder, the penis, the scrotum, and the prostate and other things like that. It does include similar things in women, like where you have like the uterus and things like that. Those aren't going to be covered so much just because there wasn't that many women injured. There's just a handful of them because they aren't typically put in situations where these injuries were common. We'll talk about my history in just a short, brief moment. Well, I was a orthopedic specialist in the Army, and I actually served at Walter Reed, which was a life flight destination for these injured soldiers, for blast injuries specifically. And I did the medical triage on most flights. I only saw one woman in a year, so it's not that common. So 70% of the 5% of those injuries did contain specific damage to the external genitalia. That number comes out to about 2,750 individuals over a 12-year period. So let's cover what they experienced. There was a 5-step medical evac from the combat medic treating them, sending them to the forward operating base where they did some more extensive patching. They would get sent to life-flighted to Landstuhl, Germany, where if there was availability, they would do forward surgical, and then they would life-flight them to Walter Reed, which an orthopedic specialist like myself would actually receive them, triage them, treat them, prep them for surgery, and then engage in surgery a number of hours later. All that only took about 12 hours, so pretty short. Nearly all of them were blast injuries, and all of them were highly comorbid. Williams and Jazur covered what was very consistent with my personal experience, that the average individual had about 2 amputations minimum. It was pretty unusual to get less than 2 amputations. It was inconsistent, or it was less common to see more than 3. Injuries could be internal with very little visual indicators, and this is true with men and women, more so with the few women that were life-flighted, in that there's a lot of internal cavities of the body that take damage with blast injury. And those things, even though they don't seem immediately stressing, they can cause compartment syndrome, which can cause long-term viability of tissue, cause significant hormone issues, and can be life-threatening. They can cause permanent damage and infertility as well as sexual function. Most of these injuries, other than genital repair, took priority for several months over genital repair, which is not something I specifically participated in, but William and Jazur covered that in quite great detail. They did take initiative to save sperm as early as possible, so that in vitro fertilization would be a possibility in the case that things were less viable than hoped. In cases where external genitalia were preserved by 50% or more, The tissue was usually able to be reconstructed, and they would be able to salvage sexual function typically, size, and also directionality were usually preserved. The psychological impacts of injury were covered by Lucas, Page, and Bennett in 2014, and Williams and Jazur in 2013. Genital injuries are usually the first thing that soldiers ask about post-injury. This is fairly consistent even with double and triple amputee cases. They have a lot of modeling very early on. I mean, even when they aren't set up in the Wounded Warrior ward, they are still preoccupied with sexual function first, and then when they get set up in the Wounded Warrior ward, there's a lot of positive modeling for mobility with extensive injuries. They see a lot of people doing very well with sometimes less than what they have, but we don't see and get as much external modeling for increased sexual function. And so there's more insecurities around that with these soldiers. Lucas and Page actually conducted a qualitative study on 13 veterans related to genital injuries in recovery. This study consisted of accumulating a bunch of statistical data about these 13 individuals, and then conducting 27 open-ended questions and analyzing those 27 questions, creating discussion around those trends and variables, and then trying to paint a picture of the overall experience. They also gave them some Likert scale questions so they could build some graphs and data on how hopeful soldiers were in recovery for increasing sexual function, how it had affected their partners, how it affected their social life, what was their experience like, etc. So we found a few interesting things from that study. Soldiers are typically open about their injuries with clinicians, but usually far more reserved with friends and family. We'll talk more about that before the end. Sexual function was reported to be far more distressing than amputations, and that is very consistent with my experience as well. Monogamy following the deployment and injury was extremely common, even in cases where these individuals were prone to having multiple partners or serial monogamy prior to the injury or prior to the deployment. That it was an incredibly strong trend, and that's stopping among those 13 veterans. They were very monogamous afterwards. Let's see here. The Dismounted Complex Blast Injury Task Force in 2011 did a large comprehensive study to determine the mental health challenges faced with genital injured soldiers. They found that these soldiers were more depressed than individuals that, comparatively did not have genital injuries, but had extensive injuries. The ones with genital injuries were more depressed. Those with genital injuries, compared to other individuals with lots of injuries, had higher rates of PTSD, more severe PTSD. Their mental health healing was notably slower. Their healing was less successful in long-term recovery. And I think it says here successful physiological healing was actually slower as well. So for counselor considerations, it's really important that you consider the multicultural aspect. There's a lot to go into multiculturalism when related to the military, but maybe the most specific one that we can address is that the military in and of itself is its own subculture with its own language, and they have their own language cants, and language cants are these things that they will throw out in public that will only be understood properly by other individuals that are within that culture or immersed in that culture. And they'll say things that might sound good but are not, and they'll say things that might sound bad but are not. And you won't know what those mean. There's also acronyms, and some of them are disguised and some of them are not, but these acronyms are used pretty casually, and sometimes there isn't actually a strong consideration as to whether the individuals around them understand their acronyms. Sometimes they aren't aware that they don't understand, or they don't care. Body language in the military is also very different. The way they sit and respect you might be communicating something other than what you are interpreting. So if you aren't culturally competent working with soldiers, you're going to have a very steep learning curve of understanding what's happening in the room psychodynamically between you and your client. You're going to misunderstand things. You're going to not catch things, and you're going to get less out of that. They're going to get less out of it as well. And lastly, you also have to know your resources and even know your local resources. The military has a very complex system, and they have different practices around systems. For example, resources, if you're trying to find military referrals, you will provide ineffective referrals without knowing a lot about the system, because the military will put up lots of phone numbers and they'll put up lots of websites. When they switch these programs over and integrate them into the other programs, they don't usually take down the old information, but it doesn't go anywhere. So it'll go to a switchboard and you'll wait on hold, but no one will ever pick up. And those kinds of things are extremely common. And we'll talk about before the end how you can start to learn to mitigate that. But knowing that that happens is really critical to avoiding it. And that isn't how the rest of the world works, but there's lots of things in the military that work a certain way that don't work that way, elsewhere. The military has its own pace and its own culture. So Lucas et al. In 2014 found that clients wanted their healthcare workers and their physicians to talk more to them about their sexuality. That was actually reported in multiple studies that I could tell as well. You need to be immediately ready to discuss the issues of sexuality with them. A lot of times you as the clinician will notice the amputation, and you'll see how they're struggling with that, and you'll be drawn to ask questions about that. But as I said before, they have a lot of modeling and positive support around amputations and a lot of positive beliefs about that, because they see people who are ahead of them making great strides, being really optimistic, being really positive. It satiates the concern and insecurity they have. It's not that there's not problems there, but they don't get that modeling with their sexuality. They don't get they don't get as much encouragement. When I was doing the life flight triage, it was always best if I could, carry an anesthesiologist with me and a urologist, because those are the two things that we were going to be dealing with pretty quickly after we were sure that they weren't going to die in 5 minutes, because they wanted to know, what's going on down there, and the urologist can be incredibly containing of the situation, and it can calm those anxieties and worries, which is really critical if you're trying to keep their blood pressure down. So visually noticeable injuries tend to get asked about more often, but it's not always their primary concern. Statistically, it's usually not their primary concern. Ask your questions about their injuries directly. Be direct about it. They will respond to you positively with direct questions. There's a culture about what your role is, with you. There's some military hierarchy in play that you can address if you want to, but they'll be more direct with you than they may actually be in their real life. You might find that they don't have a problem talking to you about their sexuality, and that might convince me in a normal case that this individual can talk about this with their friends and family, but that might not be the case with a soldier. You actually do have to ask, is this something that you're talking to your friends about? Is there something that you're open about? Is there something that you can share with your wife? And you might be surprised how oftentimes the answer is no, I don't know how to do that. And oftentimes your answer as the clinician is, the way you did it with me seemed very appropriate, and that appears to me to be a very functional way of approaching it. That is not easily connected to them. So Wilcox, Schuler, and Hansen and AM in 2015 found that TRICARE does not have specializations for sexuality or sexual function, but also concluded that specialization was actually needed. TRICARE being the main insurance that the military uses. Military soldiers do need specialized coaching on sex and intimacy after a genital injury. Injuries to the external genitalia can cause things to be different and function to be full of mental barriers and physical barriers, and they might be too intimidated by that process. And so you need to be essentially a specialized sex therapist who can work with those kinds of injuries. And you're also going to find that the high comorbidity of, again, physical deficits, try to have sex without the same number of appendages, it's not the same. The process is going to look different. Your regular rhythms aren't going to be the same thing. The game needs to change. And again, the mental barriers are pretty problematic as well, that there can be lots of negative self-talk, lots of negative beliefs. And a lot of those things can be really self-fulfilling prophecies. And if you think you can't do it, you probably won't be able to. You're also going to see the comorbidity of the PTSD. Post-traumatic stress disorder is going to inhibit sexual function as well and play a negative role in sexual function in their relationships. And you're going to have a hard time separating some of these comorbidities. You're not going to be able to triage out one disorder and say, let's focus on this and work on it so much. You'll also find that there was just as many cases of external genitalia injury as there was, say, traumatic brain injury and moderate concussion syndrome, or concussion syndrome. They weren't a perfect crossover, so not everybody had that, but you would see about 40% crossover all had traumatic brain injury and external genital injuries. That, again, you're going to find that PTSD and TBI, not so easy to separate. So, if you want to specialize with these individuals, consider specialized training in traumatic brain injury, PTSD, and sex therapy. So you're going to need to focus on a number of different things in order to tackle this comorbid grouping of disorders. One thing that you should consider just to get started if you want to start moving in the direction of working with veterans, I highly recommend that you go to militaryonesource.mil. This is probably the purest source of good information that's kept updated, kept clean, that tends to be a nice bridge between all the military services and kind of the usual accessibility that civilians are used to. There's also going to be access to free counseling on here. If you want to provide free counseling, there's a few foundations like the Military One Source and the Open Heart Foundation, that would provide you avenues for volunteering. There's websites like the vetcenter.va.gov that you're going to see that branch out into a number of different services below, including connecting you to local VA rep, and consider going to your VA clinic or getting on the phone and talking to them. The more often you get on the phone with your VA clinic, the more likely they are to help you build trainings, let you attend trainings, and even offer you some contracts to work with their veterans. And a lot of that's done just through networking with those individuals and getting on the phone, talking to them. They'll send over paperwork and it just gets hashed out on the local level. You'll also get connected through your local VA clinic with lots of different reps that serve different functions. So you can get on email lists, you can get on weekly or monthly texting lists where they'll give you the local VA bulletin board. And you'll get, again, all this is specific to each local area, but you'll get those regular updates of what's happening in your town over the weekend, what's happening next week, what's coming on, what kind of trainings are available. And you can take those. So being involved in some of those is really critical. If you want more training, if you want to get more involved, if you would like to become or work towards being competent to volunteer or take contracts on by the VA. So here are my references. There was a lot more here that we could have gone over but didn't go over, so please feel free to ask questions, send me messages. I'd love to answer any questions. I have a lot of personal experience as well as covering a lot of this data very, very carefully. We just didn't have the time to cover it all. So please feel free to contact me, and I'll try to answer those as thoroughly as I possibly can. Thank you for your time, and I hope you enjoy the other presentations. Thank you very much.